So, good evening to all. At the outset, I would like to thank the Abis Varas of the Kutralam IMA and the Shifa Hospitals for asking me to talk on this subject. So, the stroke always attracts enormous attention, but equally we have a lot of other common neurological emergencies where also the immediate care is very, very important. So today I will discuss some of the common and uncommon neurological emergencies. A 23-year-old Primary Gravida underwent LSCS under spinal anesthesia. A healthy female baby was delivered, and both the baby and the mother were transferred back to maternity ward. And approximately one and a half days later, she developed a severe headache, which was bilateral, occipital, frontal, and throbbing intensity. And the headache typically occurs in the sitting position, and it is relieved a few minutes after assuming a lying posture. The fundus and the neurological examinations were normal, and there is no meningeal signs. So this is a classical of post-dural puncture headache. It's a very common, especially the surgeons, they very frequently they experience this problem, and sometimes it may create a severe uncomfortable situation to the patient as well as the doctors. So she was advised to take plenty of oral fluids, 2.5 to 3 liters per day, and the oral caffeine was started, 300 milligram 3 times a day, with the tablet Terrified 1 tablet twice a day. Her headache has improved over a period of 5 days. So what is post-dural puncture headache? So it typically occurs 24 to 48 hours after the procedure and rarely occurs within 6 hours. The classical history is orthostatic headache, because this headache works within few minutes of sitting or standing posture and relieved by lying posture. Maybe 4 or 5 minutes after lying posture, the headache will be relieved. Usually frontal or occipital, and sometimes it can be associated with neck pain, nausea, tinnitus, hearing changes, photophobia, and rarely diplopia. So when to suspect other causes for the post-operative headache? So when the headache starts 5 days after the surgery, and headache is not positional, the post-dural headache is always a positional. It occurs only in the lying posture, occur only in the sitting posture or standing posture. If it is associated with a fever, altered sensorium, or new focal neural deficit, then probably it may be due to some other causes. The pathophysiology is the dural puncture that leads to persistent CSF leakage, so CSF hypovolemia, descent of the brain and stretching of the pain-sensitive structures. This activates the ion channels, particularly the ADP, nitric oxide, that produces a vasodilatation, and that is the cause for the headache. The risk factors for the post-dural puncture headache is the dehydration, preoperative dehydration, any systemic illness, fever, or using a large caliber or cutting needle to access the CSF. And females, pregnancy, LSCS is one of the common predisposing factor for the post-dural puncture headache, and younger age, prior history of headache, or inexperienced proceduralist. So these are some predisposing factor for the headache. Treatment is good hydration, oral fluids, avoid being in the upright position, and oral caffeine, or you can use Terrified tablet also. These two drugs act as a ADP antagonist, thereby alleviating the headache. And resistant cases, you may try 1 or 2 doses of steroids or triptans, which is used in the treatment of migraine. And finally, does not respond to any of the above measures, then probably the epidural blood patch is the last treatment. So in this procedure, 10 to 30 ml of autologous venous blood is injected into the epidural space with the help of anesthetist. This procedure creates a patch over the dural puncture to prevent the CSF leakage. The success rate is 90% with this procedure. So the next case example, a 78-year-old woman with a history of coronary artery disease admitted for an elective laparoscopic cholecystectomy due to the recurrent biliary colic. The procedure was uncomplicated and transferred to the post-operative surgical ward. On the third post-operative day, she was aggressive to the staff and was uncooperative with the medical care. She was very aggressive, had climbed up out of bed and began attempting to enter the other patient's room. She was confused, disoriented, and irritable also. So she was diagnosed with the delirium, most probably the post-operative delirium, and he was treated with dexmedetomidine infusion, 1.5 microgram per kg per hour. Despite dexmedetomidine infusion, the delirium was not controlled. He was given 2 doses of 5 milligram intravenous haloperidol, and his symptoms of delirium were relieved. The POD, post-operative delirium, is an acute medical emergency. Because why it is very important is, if the delirium is untreated, it is associated with increased hospital mortality, 2 to 4 times higher than the persons without delirium. And the mortality rate remain elevated for months to years. And it leads to a long hospital day, more expenses, and they are more prone to develop a falls and trauma and the other increased incidents of medical complications. And even if the patient develops a post-operative delirium, he will be at a more risk of developing the future dementia, future cognitive impairment. So these are the reasons we have to identify it very early, and it should be treated aggressively. So what is delirium? So delirium is a disturbances in attention. They have the reduced ability to direct, focus, and sustain the attention on any subject. The disturbance develops over a short period, usually within hours to days. And another interesting feature of delirium is a fluctuation. And sometimes the patient may be in a normal state, or sometimes there may be a very confused state, or irritable or disoriented. The additional disturbance in the cognition, language, and the visuospatial perception. And usually the very emotional disturbances like fear and depression, and sometimes the patient may be in a depressed mood, hypomanic delirium, or sometimes they may be ecstatic or euphoric. The incidence of post-op delirium is very common, and you can see in adult patients, young adult is very less, 2.5 to 4.5%. And if you see almost all the surgeries, cardiothoracic surgery 13%, even orthopedic 13%, general surgery, any surgery 13%. That's such a common problem. And the etiology of the delirium is multifactorial. We have a lot of predisposing factors and some precipitating factors also. The important predisposing factors are the age. So as the age advances, there is a reduced number of neurons, neuronal shrinkage, and there is low acetylcholine level. So that is the reason why they are more prone to develop a delirium, post-operative delirium, and low education level. And patients with already demented patient or patients in mild cognitive impairment, they are again more prone to develop post-operative delirium. So in this group of patients, advanced age or advanced age with some cognitive impairment, some memory disturbances, we have to give more importance to prevent the post-operative delirium. Of course, other medical disorders, alcohol abuse, nutritional deficiency can act as a predisposing factor for post-operative delirium. And preoperative preparation, the long duration of the fluid fasting definitely will lead to post-operative delirium. Nowadays, most of the guidelines recommends only 2-hour fasting is necessary before any even major surgeries also. So unnecessary prolonged fasting leads to dehydration, that leads to metabolic abnormalities, thereby they are more prone to develop a post-operative delirium. And some medications, especially the anticholinergics, act as used in the preoperative medication. Benzodiazepines, most of the anesthetics they use the benzodiazepine, opioid drugs, pethidine. These are all the drugs which are known to decrease the acetylcholine level, and thereby they are promoting the post-operative delirium. And these are the studies which showed that perioperative benzodiazepine increases risk of the post-operative dementia. And particularly gabapentin and pregabalin, definitely they will increase the incidence of the post-operative delirium, especially patient in orthopedic surgeon, they are planning for any surgery. If the patient previously on the gabapentinoid, it should be stopped. And opioids, again, will precipitate a post-operative delirium. And during the surgery, deep anesthesia, intraoperative blood loss, intraoperative hypoxia, hypotension, hypothermia, again predisposed to post-operative delirium. And post-operatively long ICU stay, uncontrolled pain, or the drug use which I already mentioned, benzodiazepine, anticholinergics, sepsis, they are all predisposed to develop a post-operative delirium. So what is the cause for this post-operative delirium? The surgery, the tissue damage itself initiates the inflammation. Pain, post-operative pain will initiate the inflammation. Anesthetic agents, they also incite the inflammation. So three factors produces a neuroinflammation, and that leads to microglia activation. So this microclinical activation leads to endothelial dysfunction, opening up the blood-brain barrier. So the inflammatory mediators enter into the brain and they affect the brain to cause the delirium. So very easy to diagnose the delirium. So no need to follow the guidelines. If the patient is in altered sensorium, a confused state, irritable state, motor restlessness, plus they have a memory disturbances or attention difficulties, one should very easily make a diagnosis of the post-operative delirium. So that coming to the treatment, prevention is better than the curative. The important preventive measure is especially the patient, the age is more than 70. You please avoid using the benzodiazepine, avoid anticholinergic drugs, avoid gabapentinoids, avoid opioids. This thing should be very, very important in preoperative avoidance, and long fasting that should be avoided. And guidelines recommend shortening the duration of the fasting. Less than 2 hours fasting is enough for most of the surgeries, and especially patients who are on age more than 70 with some evidence of minimal cognitive dysfunction. In these type of patients, they are more prone to develop post-operative delirium. So in these patients, probably you can give a cognitive training for 10 days and then you can take up the case for surgery. So this is called as the a comprehensive geriatric assessment. It assessed by the psychological and other specialists. And if the patient found to be in decreased mental function, then probably you can give a cognitive training. And during the surgery, you always possible use the epidural plus general anesthesia combination to reduce the incidence of the delirium, or you can use the combined epidural GA should be used. That also reduces the risk of post-operative delirium. And coming to the prevention is very, very important. And always don't use the benzodiazepine and other drugs in the preoperatively. Instead, you can use the dexmedetomidine. That's a very good drug in preventing the post-operative delirium. Or you can use the melatonin. Melatonin is an excellent prophylactic drug. The patient is above 70. If you want plan for any surgery, even preoperatively, you can put the patient on melatonin at night 3 milligram and continue post-operatively, and you can prevent the post-operative delirium. And coming to the post-operatively, the pain should be relieved at any cost. The various studies prove that the paracetamol infusion, acetaminophen infusion is commonly used, so that will definitely prevent the post-operative delirium. Or you can use the pericoxib. There's another COX-2 inhibitors. It is also if used as a post-operative pain relief. Probably you can prevent the post-operative delirium. And coming to the treatment, when the patient is in delirium, we always use haloperidol. You can use haloperidol, 0.5 milligram to maximum 5 milligram. 0.5 to 5 milligram, you can use the haloperidol. So that will alleviate all the agitated symptoms. Or you can use the dextromethorphan. Nowadays, most of the anesthetists is using the dextromethorphan in the treatment of the post-operative pain reduction. That will also control the delirium. So I can say the dextromethorphan infusion is better than the haloperidol. The next case, here a 28-year-old woman, primigravida, with 37 weeks of pregnancy, presented to acute severe headache and visual disturbances, blurring of vision in both eyes. Her antenatal BP was normal. Her blurred vision progressed to the blindness. An examination of the BP was 160, 110. Pulse rate is 100 per minute. She had a bilateral perial edema and fundus was normal and there was no focal neurological deficit. So it's an antenatal mother with a headache with a total visual loss. Next case, a 37-year-old multigravida, 30th week of gestation, admitted with a headache. She had no visual disturbances. BP was very high. Had the bilateral pedal edema, not in own hypertensive. Urine analysis revealed 2+ proteinuria, and platelet and hemoglobin was normal. Renal liver function were normal. And the second patient was treated with the magnesium sulfate, diagnosed as a preeclampsia. And after labor induction, a 3 kg baby was born with a normal vaginal delivery. After that postpartum, immediate postoperative period, she complained of a severe bilateral visual impairment, and the MRI was obtained. So with this clinical history, so any pregnant lady during labor, intra-labor period or postpartum, complaining of severe headache and visual disturbances, we can think of following differential diagnosis. And the number one is the PRES, posterior reversible encephalopathy syndrome, followed by the ischemic CVA, intracerebral hemorrhage, CVT, pituitary apoplexy, and subdural hematoma, and sometimes post-dural puncture headache. So this first case, and you can see the MRI, you can see the bilateral occipital lobe edema, and also some edema in the cerebellum also. And the second case, you can see again the same occipital white matter edema, suggestive of the PRES. PRES is one of the common manifestation of the eclampsia. So the MRI brain is a PRES is a clinical radiological findings. You have a clinical history, abrupt onset of headache with the visual disturbances, with the MRI finding will clinch the diagnosis. And BP was controlled in the first case. The BP and seizure were controlled and delivery conducted promptly. Her visual symptom improved, completely disappeared. So PRES definition is a clinical and imaging syndrome characterized by the acute headache, visual impairment, seizures and altered sensorium. Imaging cerebral edema predominantly affecting the parietal and occipital lobes. So the epidemiology of the eclampsia, the pre-eclampsia, it's very rare in Western countries. And you can see that in Finland, only 46% of eclampsia over 3 lakh deliveries. And USA, the increase markedly reduced to 8 to 5 per 1 lakh deliveries. But country like in India, the incidence is actually slightly increasing, the eclampsia and pre-eclampsia. And predisposing factor for or predictor, you can predict the particular patients which are going for a PRES. This is proved by the large prospective Indian study. And the predictors are unbooked pregnancy. The unbooked pregnancy where the eclampsia and the PRES is very common, and primi more common than the multi, and patients with the thrombocytopenia and presence of the visual impairment and the high systolic and diastolic blood pressure, again predisposed to PRES. And most of the postpartum PRES occurs within the hours of delivery. The PRES is very rare in the late postpartum period. Sometimes the postpartum eclampsia may present without a prior eclampsia. And pathogenesis of the PRES is the two important mechanisms and two important theory. The mechanism is the disordered cerebral autoregulation, endothelial damage. And theory, we have vasogenic and vasospasm. So in the vasogenic theory, increased BP, failure of the cerebral autoregulation, vasodilatation of the cerebral vessels, and opening of the tight endothelial junctions, and the edema in the occipital lobes. And according to the vasospastic theory, acute rise in the BP that produces vasospasm, hypoperfusion, ischemia, and cytotoxic edema, and the endothelial damage and the PRES. Why the PRES occurs in the sparing the white matter cortex? They occur only in the white matter. White matter is constituted by the myelinated fiber trapped in the cellular matrix of the glial cells, arterioles and capillaries. The unique structure makes brain more vulnerable to fluid accumulation. Why the posterior circulations are common? Because posterior circulation is less sympathetically innerved, whereas anterior circulation has a very good sympathetic innervation. That's why the fluids collected only in the occipital lobe. The clinical picture is very, very important. Headache, seizure, and visual disturbance and altered sensorium. The headache is hyperacute headache. Headache peaks within a minute. Hyperacute onset of headache with a severe headache with the visual disturbances will clinches the diagnosis. And seizures can occur in 80% of the patients, usually generalized tonic-clonic seizure, and typically last for a few minutes. Visual loss, visual acuity, field defect, cortical blindness or visual hallucinations, and mostly patient will develop a cortical blindness. Usually they recover fully. Sometimes, some patients they will progress on to altered sensorium from the coma to drowsiness, and sometimes they will be very deeply comatose, and sometimes they may develop a status epilepticus. So the clinical information is all the symptoms of PRES, headache, visual disturbances, seizures, altered sensorium occur very early, very acute in onset, peaks within a seconds to minutes. And investigations, the only investigation is the MRI brain with MR angiography that will confirm your diagnosis. And the CT brain, you can see the cerebral edema, and these are the MRI picture where you can see the white matter edema. Sometimes PRES can occur in the anterior circulations also. And coming to the management, the prevention is better than the treatment. Prompt recognition is very, very important. Early diagnosis. You ask the patient to come for a frequent antenatal visit, especially during the third trimester. New onset of diastolic BP 80 to 100 milligram and weight gain more than 1 kg per week. Ask the patient to return within 7 days. And women with the new onset of hypertension should be admitted and evaluated. Early treatment leads to complete reversion, and delayed treatment results in permanent visual disability, and sometimes they may die because of the complications. Treatment of seizures trigger. The Maxelf is the treatment of choice. We give a 4 gram IV loading dose, followed by the maintenance dose of 1 to 2 gram per hour. It should not be used for more than 48 hours. If the seizure remains uncontrolled, probably you can think of giving the other standard line of management like lorazepam or tafenitine infusion. And the lower the BP is very crucial, and the BP should be reduced as early as possible. The target BP is 140/60 and diastolic is 90 to 100. And you always use several drugs are available. Commonly we use is the labetalol and intravenous hydralazine. Labetalol is a very good drug. Use 20 milligram IV bolus over 3 minutes, which has got onset of action within 2 to 5 minutes, and the duration of action is 2 to 5 minutes. If the target BP is not achieved, give incremental dose. You can increase to every 20 milligram or 30 milligram, 40 milligram, like that, every 10-minute interval until you reach a maximum dose of 240 milligram. Or you can use infusion of 30 milligram of labetalol per hour for a few hours to reduce the BP. And prompt delivery is very, very important. Once the patient is stabilized, delivery of the fetus should be prioritized. All the clinical symptoms should be monitored seriously, and all the symptoms are prompt indicator for delivery. Mode of delivery is determined according to the obstetric indication, and evaluation of the maternal and fetal status mandatory before the induction of a labor. Prognosis, though PRES is a component of eclampsia, it does not affect the prognosis. Majority of the cases recover fully. Very rarely they can have a permanent loss. This is the last case. A 26-year-old female, a known epileptic, on oxcarbazepine 450 milligram twice a day. Stopped medication for 2 days due to the family issues. They developed a series of generalized seizure without regaining the consciousness, lasting more than 30 minutes, and referred for further management. So this is the classical case for status epilepticus. Status epilepticus is a neurological emergency. It is always associated with a significant morbidity and the mortality. Generally, seizures are typically self-limited. If the seizure occurs first episode, usually it disappears within less than a minute or less than 2 minutes, even with or without treatment. If the seizure extends beyond this 3 minutes or 4 minutes, definitely this patient will go in for a status epilepticus. Definitions in the past, it is defined as a seizure activity, continuous seizure activity, or occurrence of 2 or more seizures without regaining the consciousness, or the seizure lasting beyond 30 minutes. This is an old definition. The new definition is we have 2 time intervals, T1 and T2. T1 signifies the moment when the seizure typically do not cease. That's the 2 minutes. When the seizure does not stop within 2 minutes, that means this patient will go in for a status epilepticus. The T1 time point is 5 minutes. We can give maximum 5 minutes for convulsive status and 10 minutes for the non-convulsive status. And the next time frame, that's a T2. The T2 decides the time in which the cerebral damage has started. So it represents the moment the neuronal damage and the long-term consequences may occur. The T2 time point is 30 minutes. So now the current definition is 5 minutes. You have to terminate the seizure, and within 30 minutes seizure you have to terminate, otherwise we'll have some irreversible damage will be there. Hence the seizure termination is very, very important, very crucial. So this is the stages of the status epilepticus. Stage 1 is the early or impedance SC. Here a continuous or intermittent seizure lasting more than 5 minutes without full recovery of the consciousness. This is stage 1. Stage 2 is established status epilepticus. It develops 10 to 30 minutes after the onset of the first seizure. Stage 3 is a refractory seizure that persists after 2 anti-seizure medication. And super refractory is when the seizure does not respond to even anesthetic agents for 24 hours. So coming to the pathophysiology of this status epilepticus, following seizure onset, within milliseconds to seconds, the neurotransmitters are released, ion channels open and close, and protein phosphorylation occur. So all these contribute to potentially prolonged seizure. Within seconds to minutes, the receptor trafficking leads to increase in the excitatory NMDA, increase intracellular calcium, and heightened excitation, apoptosis, and mitochondrial dysfunction. So in the stage 2, that leads to drug resistance. And third stage, over minutes to hours, change in the neuropeptide level and increase the excitatory substance like P and other chemical mediators. Following weeks to months, there is a genetic and epigenetic modification and microRNA regulation. That means following status epilepticus, patient can have a permanent neurological impairment. So coming to the etiology, mostly known epileptic patients suddenly stop the medication, they will develop a status epilepticus or alcoholic withdrawal seizure, or sometimes head injury, meningitis, or inflammatory or metabolic hypoglycemia or hypernatremia, whatever the cause may be. So the common cause is, I already mentioned, known epileptic. Maybe it stop the drug or they change the medication or inappropriate compliance. Role of EEG is crucial in diagnosing the status epilepticus, particularly the non-convulsive status epilepticus. So this is coming to the management. The convulsive status epilepticus is a clinical diagnosis. No need to confirm any investigation is necessary. So initial assessment, your level of the consciousness should be assessed, ABC, disability, and monitor the vital, particularly the oxygen saturation. And all epileptic patients, status epilepticus, should be given 100% oxygen because the seizure definitely can cause hypoxia. Clinicians should be prepared to use the back and mask ventilation and intubate. And initial blood studies including serum glucose, complete metabolic panel, CBC, urine, serum, toxin level, blood should be level taken, and biotoxin level is should be asked for if the facilities are available. And CT scan of the brain is indicated urgently if the cause of the SE is unknown. So all these things should be given within 5 minutes. You can do all the procedures. And sometimes the seizure itself can cause changes in the MRI. Coming to the management, is a neurological emergency. A prolonged status can increase the risk of a cardiac, respiratory complication, neuronal loss, and brain injury and mortality. So the first is the benzodiazepine. Benzodiazepine is the cornerstone of management in the early phase of the SC. Several high-quality trials proved that benzodiazepines are highly effective in controlling the seizure. The best drug, you can use any of the drug, either lorazepam or clonazepam or midazolam or complex benzodiazepines. The best drug is IV lorazepam, 4 mg is ideal, superior to other benzodiazepine if IV access is available. If the IV access is not available, don't try for IV line. Immediately give a intramuscular midazolam 2 mg per kg, maximum 10 mg. So both are equally effective. So don't wait for some time. You may not able to get IV line. So in that patient, you immediately give a intramuscular midazolam very early. So this will arrest the seizure at the stage 1 itself. So stage 1, this is a drug of choice. Any benzodiazepine, ideally lorazepam. If IV line is not available, give midazolam. Established, there are several trials which clearly showed that the benzodiazepine is highly effective. And some of the doctors, they are afraid to give a benzodiazepine because they can cause respiratory arrest, everything. There are studies proved that if you don't give benzodiazepine intravenously or intramuscularly, these patients only the mortality is increased. So the midazolam or benzodiazepine does not produce any complications. This is the drugs which I already used: diazepam 0.2 mg kg, lorazepam 4 mg, or midazolam 4 mg. Then next stage, the moment you give the first dose, there is a lorazepam or midazolam. The next you have to give a second line. You got load with the second line AAC, most probably phosphonitine, valproate, phenobarbitone, levetiracetam, lexapro. All drugs are available in every place, even in second tier, third tier cities are available. Don't confuse. You can use any one of the drugs. All drugs are equally effective. But ideally, we use the phenytoin or phosphonitine, the dose of 18 mg per kg body weight. It should be increased over a period of 5 to 10 minutes. Or you can give levetiracetam 1 to 2 gram. You can give a bolus. Nothing will happen. Or you can have the sodium valproate. Other drugs are also available. Commonly, we use the phosphonitine and the levetiracetam. So stage 3. When the patient is not controlled with the stage 1 and stage 2, then probably you can shifting the patient to the higher centers, or if you have the ICU or anesthetic facilities, then you can treat the patient with the IV anesthetic agent. The stage 3, you can use the IV anesthesia. That's the treatment of choice. We have a lot of drugs, midazolam infusion, 0.2 milligram per kg IV over a bolus, followed by the 0.2 milligram per kg per hour. Or you can use the propofol infusion, 1 to 2 milligram per kg is a bolus dose, followed by the infusion. Or you can use the phenobarbital. Any one of the drug you can continue to use. Stage 4 is called as when you use the intravenous anesthetic for 24 hours, still you are not able to control the seizure, then it is called as super refractory. We don't have any fixed guidelines. We have to try with the trial error with any other drugs like IV ketamine, or combination of midazolam with propofol like that, or you give pyridoxine infusion or magnesium sulfate. Lot of other drugs are there. We don't have any guideline. Ketamine is supposed to be ideal in this type of super refractory status epilepticus. Or you can use the combined approach, propofol with the midazolam. And super refractory is only for institutionalized care. The other drugs or other methods like electroconvulsive therapy, transcranial magnetic stimulation, this is only for a super refractory status epilepticus. So this is the management. The first stage 1, give a benzodiazepine. Don't hesitate to give a benzodiazepine. Immediately followed by the loading dose of levetiracetam or sodium valproate or fosphenytoin. If not controlled, you think of giving the IV propofol or IV midazolam infusion or thiopentone sodium. The outcome is 1/3 they will die, and 1/3 they will recover completely, and 1/3 will have a severe disability. The another important is the non-convulsive status. Here the patient is presented with only with altered sensorium, with the minimal jerky movements. Actually, patient is in coma, and you do all the investigations for coma, imaging studies, metabolic parameters, everything will be normal. And if you take the EEG, you can confirm the diagnosis. It's called the non-convulsive status, presenting as a coma. And this which we can see one girl and one mother presenting as the altered sensory for 2 days. And if you carefully see some eyelid twitching movement, and you can see some automatic movements, turning movement of the child, the blank stare with the drowsy state. So this is called as a non-convulsive status, confirmed only by the EEG. Is the EEG criteria. And this type of seizure, non-convulsive status, the drug of choice is the benzodiazepine. Midazolam infusion will immediately control the seizure activity, and the patient will become normal. Conclusion: the status epilepticus is acute neurological emergency. Time is brain. Initiation is very early. Treatment is essential. Early adequate dose of benzodiazepine has to be given in the stage 1 itself, whether intravenous or IV. Don't bother about the side effects. Adequate second line AEC is also important. Midazolam and propofol are preferred drugs if refractory and super refractory. Ketamine has a potential role. Thank you for the patience here.